We talk much about value. All of us in healthcare say we are delivering value. It's really a pretty simple equation, quality minus cost. So why is it so hard to measure and therefore to buy and to sell intelligently? So I'm Jim Trounson, mayor of our little virtual healthcare town of Medvale. We welcome you to this month's Medvale Lyceum, where we invite our citizens and friends to gather to learn and talk about a topic that will help them to deliver better health to their communities. We shamelessly stole this idea from another town, ancient Athens, invited their citizens to free lectures. Presenters like Aristotle would share ideas worth consideration. They called those lyceums. We do the same. So today we're gonna uh, 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 do an exploration here. And so, why is it so hard to value in healthcare? If you're a provider, how will you know if efforts and money spent to enhance value are paying off? If you are selling services to a provider, how can you make a compelling argument that they will be able to tell a difference? Someone who makes his living by answering these questions is Craig Solid. He's the founder of Epiphanis uh, Solid Research Group. And in 40 minutes, you're going to know about three things. What are you likely to miss when assessing value? Two, key questions to ask when valuing the value you are either selling or buying. Three, what does behavioral psychology have to do with value in healthcare? Craig was brought to us by Medvalista Pam. So, Pam, I've asked you to maybe offer a little bit more of an introduction of Craig, please.
Yeah, thank you. It is my honor to share Craig with you today. Dr. Craig Solid is the owner and principal of Solid Research Group. Solid Research Group is a healthcare consultancy, and they're focused on helping organizations understand, quantify, and demonstrate value, usually through peer reviewed papers and research. His clients are across the globe in the US, Europe, Australia, and they include healthcare and medtech startups, large device companies like Medtronic, Boston Scientific, and large academic institutions. He holds a master's in statistics and a PhD in health economics. He's authored or co authored over 60 peer reviewed papers and multiple books, many of which focus on demonstrating value. I am a student of his work. He shares many values and goals with you and our fellow Medvalistas, and that's to improve healthcare. I formed a great friendship with Craig over the years as we learned from each other, and it is my honor to introduce him and share him with you today. Craig, take it away.
Thank you very much. Appreciate it. I'm very happy to be here. Thank you for inviting me, and I'm excited for our conversation.
Craig, why don't you start off by elaborating on some of what Pam was saying about your experience, what you like to do, what Solid Research Group, any more details that we should have in mind as we get into this conversation?
Sure. Well, I'm trained as a researcher. My background, I worked many years as an epidemiologist and health economist for a nonprofit, writing papers and going to conferences. And over the years, as value became sort of more ubiquitous and talked about, but the resources of how do you do that and what does it mean did not grow at the same rate. I found a lot of need from all types of organizations to help figure out what do we actually mean, how do we measure it, how do we compare it. And so it's just sort of grown over the years as I've tried to help further that conversation around value.
Mhm. Well, the work you're doing is all within healthcare, right?
Yes, yes, it is. It's all healthcare, and it's on both sides. So there are groups that want to convince others of the value of their solution, whether that's a device, whether that's a program, whether that's They want funding from a federal institution, but also on the other side, groups that say, well, how do we make decisions, right? We need to make a decision about whether we invest in this or pursue this. How do we know? Like, we can do some of it, but there's a lot that goes into that calculation, some of which is monetary, but a lot of which is not. So how do we balance those different components to figure out what is in the best interest for our organization and our members?
Craig, in your conversations with Pam and me, you know quite a bit about Medvale. So you realize that here on the screen, we've got uh, providers, hospitals, medical groups, lots of representatives that are the consumers of the others that are sellers. Well, we got the buyers and the sellers, and so I'm excited about this because you can talk from both sides of that. And so I'll maybe direct some of the questions to one of the other components there, and then when we get into our confidential part for the last 30 minutes, please, all of you, pitch in with whatever you might glean from Craig. Well, and then Craig warned me this morning as we were getting ready that he's kind of a college professor. He is a college professor and an academic. He writes books, he writes papers. And he said, Jim, if I get a little bit carried away about that, ask me to translate it into English. So he's invited me to make sure that we're understanding this something that's pretty technical. So you may uh, uh, hear me asking him to interpret some of this. So, Craig, can value be quantified? Is it possible for different healthcare institutions, providers to say we are different? How do you compare St. Elsewhere to St. somebody else?
Yes, value can be quantified and compared, or at least some of it can. I think, as an industry, we've tried to sort of objectify it. We've tried to sort of put it in a box, and the whole, quality per dollar spent, which is useful in some situations, doesn't at the same time doesn't begin to encompass everything that it is in value. I always say that, value is subjective, and I think that's one of the things that we always forget. Even the stuff that you can quantify, you take that to a group and you present that quantity, whether that is enough is often a subjective um, assessment based on their unique situation. So value is situational. Value is different based on perspective. I'm shocked. I'm still shocked at how often in the industry we talk about value without being specific about value to whom, right? Any of the ones of the CMS's value-based programs will value to whom? Mostly to CMS, right? And so I think we in our conversations we talk about value, but we don't get specific about it. So yes, it can be compared when you get specific about things like, here's how I'm going to define value in this situation and circumstance, value to whom, from whose perspective, over what time period. Here's how I'm going to measure it. Here's what's going to be included and how I'm going to measure it. And then here's how I'm going to compare it. Because a lot of times the question I get is, well, how do I know if it's enough? Or what's a good, for example, ROI? And the answer is it depends, right? You might find that a financial ROI of 0 is sufficient if you also get along with it a whole bunch of non-monetary value to your patients, to your staff, to your members, right? So there's not one single metric or one single way of doing it or one single definition that's applicable everywhere. And I think we want there to be, and there just isn't. So it is comparable, but it takes some thought up front to sort of define the parameters of how you're gonna do that.
Well, Craig, could you give us an example of even a number that you've delivered or you've helped a seller or a buyer to deliver that would be an indicator of value?
Yes. I mean, I'll give you. I have many. The one that comes to mind often to illustrate the sort of multifaceted aspect of value is I talked with one group that had they were a startup and they had a device. It was an external urinary capture device for women in the ICU, and it was going to reduce infections and all sorts of problems that come with that. And they got in front of some health systems, and the health system said, "Well, we ran the numbers, and your device is going to produce an ROI of maybe 8 to 1 or 10 to 1 for us." And then they said, "But we're not going to buy from you." And the reason is this would require our ICU nurses to do an extra step in the ICU. And with the nursing shortage and how overworked they are, we're not going to ask them to do anything else. So this was a situation where you can come up with a lot of monetary value. But if some of that value is misaligned, meaning the people who are asked to incur additional costs, whether that's monetary or non-monetary, are not the same as those who receive benefits, you struggle with implementation and adoption across the different settings. Now, if they were to approach a different health system and have the exact same calculations, perhaps that other health system in a different situation would find that that would be enough. So those are there's many examples of groups saying, what is the number I need to take to different health systems? Or a health system says, what is the number that we should expect from groups that come to us? And the answer is it depends on your situation, their situation, the circumstances, the timing, everything involved in there. So it really is about getting clear about how are we going to make this decision? What are the criteria for yes and no? And then how do we sort of structure our evaluation to give us the information to make that decision as in the best way possible?
Well, the example you used, could that seller have come up with a value to the nurse? Because it looked like that was negative, but somebody else might come in and we can save a nurse this much time in an ICU. And that
Well,
would be an argument to use in
yeah.
buying.
Well, and this group came to me because they had the interaction, and they sort of came to me and said, "What should we do about it?" And I said, "Well, this would have been a wonderful conversation, 6 months or a year ago, because these are the kinds of things that often groups fail to think about early enough." In your intro, you talked about some of the mistakes that are made. Usually, value is not thought about early enough. It's done sort of retrospectively. Hey, we have these clinical benefits. Let's go back and figure out how much it's worth. This
Mhm,
is a situation where, yes, if thought of initially, that startup could have potentially talked to ICU nurses and said, Here's what we're proposing. What do you think?" And would have gotten some of that feedback about, "That's an extra step. I don't have time to do that. It's just not going to happen unless the following is true," or something like that. So, one of my favorite questions for startups like that is to ask questions like, what would need to be true? What would need to be true for you as an ICU nurse to find value in this? Oh, well, it would have to replace this other step, or I would need to be able to really believe that this is going to help my patients. Because the other thing that happens, and again, this gets into the sort of the perspective and individual opinions. A lot of times, it's in certain health systems or whatever, they'll say, "Well, I understand that infections are a problem for some people. It's not a problem for us," right? And that gets into demand for a solution and things like that. Because just because there's a problem in healthcare doesn't mean that people are clamoring always to solve it. So
mhm,
I think early on that group could have engaged ICU nurses. They could have thought about how can we structure this in a way that doesn't impose an additional cost on those nurses. What else would need to be true? And sort of the earlier they think about it, the more likely they are to be able to address it before they actually get in front of a health system to try and sell it.
mhm. And that could have been done in the design phase, not and then that would led into the selling phase. And by the way, besides the 8 to 1 ROI, your nurses are gonna like this or to have done their homework
Right.
better.
Yeah, exactly. And that also gets into non-monetary value because nurse satisfaction, lower turnover, better attaining more talent, all these sort of things that relate to, just a better situation for all involved, patients and providers. Yes, in the design stage. So I usually recommend, for these startups, at least think about value early on. Think about the sources of value. Where is the value going to come from? Even if you can't quantify it. A common thing for a lot of startups to say is, "Oh, we're going to save providers time, and that's our big benefit." And then I say, "Well, how do you quantify that? How do you monetize that?" Because anything like that for startups, I say it those you need something that is three things. It needs to be measurable, monetizable, and attributable to your device or your solution. If it's those three things, you have an argument, and you might run into problems with any one of those. But saving time is great, but you need to translate that into something that is actually of value to a provider or a health system in a way that they think about it. Maybe that means more capacity. Maybe that means less burnout, whatever it is. So you do need to think about it early on, because that's when you start identifying where am I going to run into problems when I start talking to health systems and providers. Where are they going to start pushing back, so that you can address those early on as opposed to after the fact.
So in the measurable, monetizable, attributable triad, tell us about attributable.
Yeah, so back to CMS, as an example, their programs, for example, on hospital readmission reduction. Readmissions are clearly measurable and they're clearly monetizable. The problem that a lot of people had with those programs was, can you actually attribute the programs that CMS promoted to reduce rehospitalizations? How much of effect did that actually have? There were studies on, hey, the rate was already decreasing. Clinicians chimed in and said there's a million factors that influence whether or not a patient's going to go back to the hospital. A lot of them are, rest with the patient. So attribution can often be a problem, and it's one that, you know, um, clinical trials can help, right? You can directly attribute the clinical benefits from your solution or from an intervention, if it's a quality improvement of an intervention or something like that, that you can directly attribute to that. If you can do that, then that helps. Um,
Mhm.
as you're quantifying it, sometimes you can make assumptions. You can say, well, let's assume that 80% of the improvement, or 50%, or 20% of the improvement we can directly attribute to our intervention or our solution. Sometimes that's enough, because if you can show, hey, there's a monetary benefit when we only assume a 20% attribution, that gives people comfort to say, okay, well, it's probably more than that, but that's a conservative estimate, and it's still demonstrated value. So the attribution is something that people don't tend to think about as much, or they just assume that other people will see it the same way that they do, right? Well, it's obvious to me that there's a direct link, whereas others would say, well, that's not been my experience. Um, yes, measurable and monetizable, you can usually tell right away. It's the attribution that can be hard. And one of the exercises that groups can do, and whether this is, you're a nursing home trying to reduce falls, or you're anything, and you say, well, if we had some intervention or a solution, what are all the possible benefits? And then of that list, you go through and you pick out which ones are measurable, monetizable, and attributable. It'll be a much smaller list, but you will now have a list of potential benefits that you say, okay, if we want to measure this, we got to make sure that we collect information on these particular benefits, because these are the ones that are all three of those things, and that we can use to actually estimate some type of monetary benefit associated with this change or intervention.
Craig, we have a number of providers here on the screen, representing hospitals, medical groups, networks of clinics. When they come to you, what do they usually ask you to help them with? It's all about value, but are they typically focused on some aspect of that, or value is defined by a particular group or payers, uh, safety, patience, uh, saving money.
It kind of depends. So there's two main circumstances that I'll get approached with. One is if they are applying for external funding to CMS, to some other grant, and some of the conditions of that application, it's been more common for them to start asking for an ROI calculation. And usually when it's asked for that, it's like one sentence and gives no parameters as to what's included in that. Usually because the funding source doesn't really know what they want, they just think it sounds good and it would be a good thing to do. So we will talk through the process of how would we do that, ROI to whom, how would we quantify that, what should be included. The other thing is if they're trying to make a decision about something internal, what type of investment to make, how to evaluate whether a quality improvement intervention is going to be worth it, and so to speak. So in those situations, that's when we go through and figure out, well, how are you going to define value? Is it going to be based on payer metrics or a reimbursement mechanism? Is it going to be based on staff satisfaction? Is it going to be based on patient outcomes? Is it going to be based on some combination of all of them?
Mhm.
And over what time period? The next quarter, the next year, the next 5 years? And then we go through things like, well, what's measurable, what's monetizable, what's attributable, how will you know? How are you going to evaluate whether what you see is reasonable? What type of metrics? ROI, savings per patient, payback period, all these different things. And so it's usually through those conversations that additional information comes out and says, oh, well, actually, this is being championed by this group over here or this department. So it really needs to include some of their metrics and things like that. Great. So usually when they come to me, they have sort of a general idea of, we want to be able to show that this intervention is worth it. And then the process is to go through and say, okay, what does that mean? And how would we do that in a way that is credible and compelling? So it's based and rooted in sort of research and real things, but is a compelling enough argument that you can get buy-in from the staff and from the systems, to sort of undertake the intervention and be motivated to do it.
Yeah. Well, then what mistakes do you see that providers are making as they embark on these initiatives to improve quality, improve value?
Well, I think, and I've alluded to it, I think, we've all been sort of conditioned to think of value very narrowly and think of it as um, surrounded or sort of focused on a quality measure or some other measure that someone else has told us this is important. This is important for your facility and your hospital to do this and to meet this standard. And then the goal is, how can we meet that standard with the least amount of money? So it's really quality per dollar spent. And I really want people to think of it more broadly than that. What does value actually mean to us? What would be valuable for us? Um, and let's not just think about it from the perspective of the payer or from CMS or from some external evaluating committee. Obviously, we have to do something because there's regulations and we have audits and all these things that measure us. But um, usually they don't think of it broadly enough, and they get sort of bogged down in some quality measure that, by the way, quality is also subjective. So there's a there's a whole separate conversation about the effectiveness and the appropriateness of quality measures to sort of really represent quality, but that's a separate issue.
Should access be part of the equation as we're looking at uh, value of what we're delivering?
That is a great question. My answer is, I think you'd be surprised at what potentially can be included in your assessment of value. Access very well might be an important thing to include in value. There are studies that have demonstrated that there's value in hope. Patients who are offered, cancer patients who are offered regimens that have a similar average survival, but have the potential of a longer survival in some small probability, will overwhelmingly pick the one that has the potential or the hope for longer survival. So you can make a case for almost anything being of value to you or your organization. Access, reducing disparities, quality of life, emotional well-being, reduced caregiver burden, increased member retention. I mean, you can go through the list. There's hundreds of things that might be of value to you. The trick is really figuring out how are we going to measure those. If we can't monetize them, how would we quantify them and use them as sort of a metric for whether what we're trying to do increases that value, and what do we compare it to? What is our sort of our standard? So short answer is yes, it can be part of it, and the long answer is there's any number of things that might be reasonable to include as part of that value.
Well, let's use access as an example of something we want to measure. How do you measure?
Well, it would depend on the situation, right? And there might be sort of data-driven ways to assess value, right? You could talk about number of visits, or I do a lot with primary care organizations, and they are interested in things like continuity of care and comprehensiveness of care. And so there's ways to, how often does the same person have multiple visits with the same physician? Does that say something about their access to that physician or access to any physician? You can ask patients and the community, right? And even in clinical trials, patient-reported outcomes are exploding as part of clinical trials and being recognized as an important part of the entire sort of healthcare effectiveness and value of care delivery. So it would depend on the situation, but you could measure it any number of ways.
Mhm. Well, a number of folks are making the argument that quality doesn't cost money. It actually saves money. You spend money to save money. And so, in terms of reconstructions after a surgery, readmissions. So, those of us that are on this value bandwagon, which we all need to be, can we make that argument that quality value is kind of free?
Well, I see where you're going. Um, Honestly, a lot of my clients who are trying to pitch to payers and providers, if they walked in and said, give us X number of dollars, it's actually going to save you money, I don't know how far they'd get in that conversation. I understand the sentiment, and I'm a little too much of an analyst and sort of pragmatist to say, let's lay out the costs and the benefits and show that over a certain amount of time, you will recoup your investment. It is a good investment. You're paying up front now, and you're going to gain that back. If you want to interpret that as it was actually free or you made money by investing in quality, I'll take that argument. But I think there's a lot of your group could probably raise their hand and give examples of where that wasn't true, right? Where they invested in a quality improvement initiative or a new piece of equipment, and they said, that wasn't free, and we didn't get back what we did. So I think evaluating how we measure that and how we compare that is an integral part of that. And the better you get at that, the better decisions you will make, and the more often it will be the case that you will recoup your investment and more in the future.
So we have a new interest group on physician well-being. How does that play into this? What's the impact on these discussions about value and quality on physician burnout? Does it hurt? Does it help?
Yeah, I mean, physician well-being is an example of that has value just in and of itself, right? I mean, so for a lot of groups, they would just look at that and say, if we can improve our clinician and physician and nurse well-being and job satisfaction, that's worth it. And it might even be situations where we're willing to incur sort of a negative financial return to produce that because we believe in it. At
Mhm.
the same time, if you go um, deeper into what that does for you, you could link it to things like less turnover, better retention, better acquisition, better patient outcomes, right? There's studies that directly link clinician burnout to adverse events for patients. That opens you up to litigation. There's all that sort of stuff. So it has value in and of itself, but you can very easily draw a line between improved clinician well-being and lower costs, lower risk of adverse events, lower exposure, things like that, and can do so in the pretty short term. Because that's the other thing that's part of this. A lot of times, especially payers will tell you, I need to see a return, and I'm not interested in a return 2 years from now. I want what return is this going to give to me in the next quarter, in this fiscal year? So physician burnout and well-being very quickly and closely can be tied to some financial benefits for the uh, organization.
Craig, do you see any providers as able to market the fact that there's a perception that their value is higher than the competition? That'd be something pretty nice to get a reputation for.
Well, I think so. You said two things there. I think marketing something is different than your reputation, and I think the reputation is definitely something that most organizations understand. And they understand that information spreads throughout this network of clinicians and providers in informal ways and at conferences and over email and through alumni groups and things like that. And I guarantee you that clinicians know that's a great place to work. That's not a great place to work. And I guarantee you that whether the organization knows it or not, that has financial implications for them. So I don't know of any providers who formally market on that, but I know for a fact that there are groups and hospitals, health systems where clinicians know that that's a good place, a less than good place to work.
Yeah. So, tell me about behavioral psychology. How does that play into this discussion?
Yeah, and it used to be called behavioral economics, quite honestly, and it's sort of been transferred into the name of it. But this really deals with the idea that value is subjective and it's based on your perspective and your situation. And behavioral economics really gets into these ideas of bias, right? So there's confirmation bias, there's status quo bias, there's heuristics related to recency and availability and things like that. So if you are talking to a group about the value of an intervention, quality improvement, your solution, they're going to view that through their own lens of their experiences, their opinions, and their situation. So maybe they have seen something similar and it didn't work. Maybe they have a strong opinion about their own facility and group about what they're already doing to address the issue that you've brought up and are trying to solve. Um, Status quo bias is hard because it's like, well, we already have a way that we do this. This is going to be a hassle to implement. Like, why am I going to do this? Why am I going to have another screen to look at? Like, that's really hard. I don't see any problem with the way it's going. So, there's a lot that can be learned not only about some of that presentation, but in how information is spread, how it gets adopted across the industry, and how you sort of think about how people talk with each other, interact with each other, how each facility is unique, even if it's similar. It's unique in its makeup of individuals and its physical environment and geographic location. So it's all about sort of perception and how people and the lens through which people look at things.
Thank you. And as we're getting ready to open this up, any other thoughts about what kind of analysis should we do as a buyer or as a seller of value? So, any kind of last thoughts to summarize this, Craig? Any advice for us as we're dealing with enhancing value?
Yeah, I mean, I think the right analysis is going to be different for each situation. But I think that one thing that I always encourage groups to do is to not ignore the inherent uncertainty and variability that always comes with these things. You often see analyses where groups will produce one number. We think the ROI for this intervention is going to be this, but that's usually based on a whole bunch of assumptions, right? How many people you can recruit, the time it's going to take, the inputs, the effectiveness, da, 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 da. So I always encourage groups, look into what would happen if you varied some of that. Like, what's a best case and worst case scenario? That will help you understand what is the risk that we're taking on when we do this, and also what are the real drivers? What really needs to be true if this is going to be effective? Is it really land on how effective the intervention is, or is it really a function of the timing or what it is? So think about that variability, think about that uncertainty, and include that in whatever analysis that you do.
Do you have any good examples of again, a provider, whether it's a hospital or a group of doctors, that are saying, we're going to increase value and everybody in our organization is going to know that we're going to go from here to there? Is there anything that can be dumbed down, made easy to remember, and repeat for hundreds of employees, as they're trained, as leaders are trying to get them united about creating value?
I mean, I think I would advise, remember that everyone in your facility and your group also has a subjective opinion of the value of whatever you're proposing. So be clear about, here's how we are considering value in this case. Here's how we are measuring it. We are linking value to increased satisfaction, or we're linking it to increased revenues, or we're linking it to reduced patient adverse outcomes, or whatever it is. The more you can get specific about it, the more others can understand, here is the goal, here's what we're trying to do, here's why they think that is valuable and valuable to all of us. And that'll potentially help get more people on board. Otherwise, they might say, well, I disagree. Why do they think that's valuable? I don't understand. I think of it this way, or in my situation or my department, I'm thinking of it this way. So be specific and define it and include them if possible in some of these definitions.
Craig
Great.
and Jim, we had a great question in the chat that connects to this
Thank you.
conversation, and I think we should talk about it here before we stop the recording, and that's around the risk of pursuing value. So this I hope Jim doesn't care that Dr. Souza doesn't care that I asked this question. Okay. He says, it seems when value can be simplified to perhaps a single outcome metric and the cost of getting it, the risk is smaller and the opportunity might not be well defined. On the other hand, if you do a more complete value analysis up front, looking at multiple metrics, the risk of achieving value might be higher, more complex, but the visibility to the potential benefit might be more complete. What are your thoughts on this? That's a phenomenal question. Thank you.
I think that most groups would benefit from being more prepared. So maybe there's some happy middle. Like, here is the very simple metric that we want to make sure to achieve. However, we also want to use this to inform future decisions. So we want to make sure that we outline all of the potential value sources, where it comes from, how we're going to measure that, so that when we look back, whether it was successful or not, we are more likely to pinpoint, why was it successful or not? What drove it? Oh, we didn't get the recruitment that we thought. If we had, then we would have done it. Or we totally misjudged what the effectiveness was or the timing that it was going to take. Though the more information you can have about how are you measuring it, what are the components, how do they affect it, the better you will be for the future. So that even if that one wasn't successful, you are more likely to be successful in future ones where you know more. Because a lot of times value is just sort of, let's use it for this thing and then forget about it, and the next time we'll reinvent it and rethink about it. So that's my initial thought, but that's a wonderful question.
Yeah. Well, and we can do a deeper dive into that during our open session here momentarily. Craig, any closing thoughts or summary before we go to that?
No, I mean, I really appreciate the opportunity to talk with you. I encourage all of you to think about value. I know you have a million things to think about and a million things that influence your decisions, but just having some of this thought process and thinking of value more holistically than simply quality per dollar spent, I think will help you make decisions and sort of understand how to approach different situations.
Okay, well, thank you so much, Craig, for helping us to uh, get a better grip of this complex question.